This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Dr. Meera Beharry, board certified in both pediatrics and adolescent medicine. Dr. Beharry is the CEO of her own consulting firm, Adolescent Medicine Consulting, and a concierge consultative private practice, Healthy Horizons Pediatrics, with the goals of improving access to medical care for adolescents and young adults experiencing a variety of health issues. Links to Dr. Beharry's contact information can be found in the show notes.
There can be no keener revelation of a society's soul than the way in which it treats its children. Nelson Mandela. Welcome to Once Shattered, Picking Up the Pieces, episode 111, Pediatric Anxiety, Depression, and COVID, with Dr. Meera Beharry. Thank you all for joining us today. It's great to be starting our second season of podcasts. We're back by popular demand. And I'd like to welcome my husband, best friend and soulmate, Jack Major. And unfortunately today, our dear friend and fellow advocate, Ellen Bennett, can't be with us, but she will be back for our next episode and all the following ones.
Welcome, everyone. Welcome. Thank you for joining us for our second season. And we'll really miss Ellen today. I'll try to add a little color because she's our color person, but she'll be back for our next podcast. So hope she feels better. Okay. Welcome, Dr. Beharry, joining us all the way from sunny Florida.
Thank you for having me. I really appreciate that you've made this space for us to have this discussion and to share our experiences and knowledge. And gosh, I really thank you for that great introduction to when you're just doing life, you don't stop and get to think about, oh yeah, that was a lot of stuff. And you made it sound like I've done amazing things. I'm like, I want to know that person. So, thank you.
Well, we are very honored to have you with us today. And can't wait to hear more about your findings in the state of our children's mental health, especially during COVID, post-COVID, and thank you.
You must be pretty excited about your article that's recently published in Pediatric Anxiety and Depression in the Time of COVID. It's in the Pediatric Annals, right?
Yes, ma'am. Yes, I am excited. I am really glad that they decided to have an issue focused on pediatric mental health. And for folks who are interested in learning more about this topic, I encourage them to check out the whole issue. There are leaders in the field who've reported their thoughts and findings in that issue. Dr. Celia Neville, Dr. May Lau, Dr. Maria Monge. Some of the topics include mental health issues specifically for military-involved families. Dr. Monge and one of her colleagues wrote about eating disorders, which we've seen an increase of eating disorder incidence and prevalence during the pandemic. May Lau wrote about pediatric suicidality and the increases we've seen with that. And Dr. Neville wrote about social media and just some of the changes that we've seen. So it's a little compendium of everything we know now, and everything is changing is one of the challenges with writing the article. From the time we made the first draft to the time we were ready to publish, so much has changed and will continue to change.
And I just want to remind our listeners that all the links for the article and for Dr. Beharry will be in the show notes.
I printed out the article and one of the things that caught my eye was on the second page, and I was surprised to read that any given time that estimates show that youth worldwide have a 7% incidence of anxiety disorder. But then it also followed up and said in the United States, it's 20 to 30% will have an anxiety disorder. So it's 3 to 4 times more prevalent in the United States than worldwide.
That is what we're seeing. And I always ask people when we look at these numbers to think about why are we seeing that? Is there something inherently different about being in America that makes us more anxious? Is it television? Is it the media? Is it something else? Is it the fact that pretty much all of us here are migrants here and we're in this big melting pot and everybody's different and all of that good and bad that comes with that, all of the challenges? Or is it that in other countries, they're still so busy, figuring out what's going on with infectious diseases? What are some of the other health issues that they have not yet had a focus on mental health and a time to have people diagnose and treat anxiety, depression, and all of these conditions? Is it there, but it's just not talked about yet?
And in the article too, it also said sometimes it's misdiagnosed. Anxiety is misdiagnosed as attention deficit disorder, irritable bowel syndrome, and the after effects of COVID.
Yes. I think even, before COVID, we would have patients who, when they're young and they're showing some signs of attention deficit disorder, they're not paying attention, they're fidgety. This is their anxiety showing up. And it is categorized when you think of how we diagnose ADD, we do symptom questionnaires by observations of the adults. And if it's a really young kid, they might not be able to verbalize their anxiety in those moments. So that's one way that anxiety sometimes gets misdiagnosed as ADD or ADHD, or sometimes they can be co-occurring as well, that a kid can have ADD and anxiety. And in terms of irritable bowel syndrome, it can be either a misdiagnosis or also a co-occurring diagnosis. I have many of my patients who have irritable bowel syndrome who notice that when they are emotionally upset, kind of like some patients with asthma too, when they're emotionally upset, their symptoms flare up. We know that the brain and the gut are intimately connected and develop at the same time embryologically. And, it's why our language has these words. I had a gut feeling, I got butterflies in my stomach, all of these things, so that mind-body connection is there. And sometimes people feel more safe when they say, I have stomach issues, I'm feeling constipated, bloated, have diarrhea, rather than saying, I'm anxious and stressed in this social situation.
Mm-hmm. I know the Mayan culture way back then called your stomach your little brain. So I think that's really interesting how much knowledge they had then, right?
And in terms of the long COVID, the post-acute sequelae of SARS-CoV infection, PASC, as we're calling it, I prefer long COVID, way easier to say. Yeah. We are still figuring out what that is. We're figuring out what that is in adults. And we are seeing that in some of the patients who've had COVID, whether they were symptomatic or asymptomatic, that they are having problems concentrating. They've had changes to their sleep habits. They've had maybe changes to their eating habits. And when you think of the questions we ask for anxiety and depression, those are part of those screening questions. Have you had a change in your sleep? Have you had a change in your appetite, change in energy levels? So sometimes patients might be diagnosed as a long COVID and may also have depression, or it may be that they have depression and some prolonged symptoms from allergies or the actual COVID infection that are giving them the physical symptoms of sinus problems and upper respiratory infections. So those are some of the things that we're still figuring out. And, it's not mutually exclusive. You can have ADD and anxiety or depression. And sometimes kids also, if they've had ADD when they were younger and they start growing out of it, or if they're in challenging social situations, they might not completely understand everything that's going on and be more anxious and more depressed in some of those situations. So it really does take a careful eye to tease out what's what. Mm-hmm. And I think the first step is doing what we're doing, talking about it and thinking about it.
Right. Yeah. How much of the long COVID do you think is due to inflammation?
Ooh, that's like $1 million question, isn't it? Maybe $1 trillion question. I don't know. I think perhaps a lot of it, to draw parallels to the epidemic that occurred when I was a teenager, or a tweenager, I guess. Mm-hmm. When HIV/AIDS came up, there was so much we didn't know about viruses, and we know so much more now. It's part of how we developed so many other medications. And I think COVID will teach us more about the long-term effects of all infections, whether that's COVID itself or like to think about another one, polio. We didn't know that there was a post-polio syndrome until people got way older. And we realized, gosh, those who survived polio when they were younger had more challenges in their senior years.
This is the first time I've heard the long COVID phrase, and I had heard that before.
I've heard long haulers before. I've heard some people
long haulers
too.
Yeah. So we're
the unmedical terminology. Probably.
So we're a little over 2 years into this now, right? And it says that some of these symptoms can begin anywhere from 4 to up to 12 weeks after the infection, and so do they continue to last? For people that had it early on in 2020 or whatever and showed symptoms afterwards, do you find they're still having those symptoms of anxiety?
That's a great question. I don't know the percentage of people who had the early on long COVID infection. And to be honest, some of those patients might have not been diagnosed with long COVID, and they might just not even know that that's a term that's out there because they had infection, went on about their life, and are now struggling. And unless they're, keeping up with this information, they might not know. And we would, to do, I guess, a really properly designed study, we would need to look at all of the people who we knew were positive. And I don't know that we have that data mining in place as yet. But I am hopeful that now that we're talking about it, that the patients, especially the kids and adolescents who were infected over the past year, we're following them a little bit more.
Yeah. I mean, I know a lot of people that had it or, even had the shot and then something happened, they had some symptom and they blamed it on having COVID or even having the vaccine. But they didn't report it to anyone. They were just anecdotally telling friends and family, I've got this. And so nothing was reported to the CDC to tabulate anything.
That's a great point. Like, I don't know. I'm going to look it up after this. Is there a long COVID registry? Like when we get a vaccine when we give vaccines in pediatrics all the time, we have like the vaccine adverse event reporting system and a central number we can call. I don't know if there's a central number somewhere. I'm hoping one of the institutions out there has something where if, you think you have long COVID, you can call.
Yeah. But even that, unless a patient comes back and tells you they had an adverse reaction, so you're not going to report anything. So
COVID has disrupted so much of normal family life: school, work, routines, social gatherings, athletics, and spiritual affiliations. These disruptions have impacted all of us. But the effect on our children has been profound, certainly more than I would have imagined. As a pediatrician, when, during the time of COVID, did you begin to notice depression and anxiety affecting your patients at a higher rate? And you mentioned that adults have developed coping skills to deal with stressful times in their lives and that children and adolescents do not. So could you just expound on those two things for us a little bit?
Yes, I love these questions. So for me, as an adolescent medicine specialist, most of the patients are referred to me, and I see perhaps a higher percentage of patients who have anxiety and depression and eating disorders and other challenges. So definitely I saw it right away. And from my colleagues in general peds, pretty much right away, because we took away something that is developmentally normal. I mean, when you think about it, it was, 2 years ago, springtime, when people start thinking about prom and spring break, and some people were graduating, and all of a sudden we're on lockdown and all of these things are happening, and nobody knew how quickly things were spreading. Nobody knew how to best keep themselves safe. I get chills just thinking about it now. I still remember going to the grocery store and there was nothing on the shelves. That's anxiety provoking, and for us, we have some resources to deal with it sometimes, but for the kids, they might not have, or some parents were at the limits of their coping to begin with. And that reflected in how the kids were showing up. So I saw it pretty much right away. And I think most of my colleagues saw it right away. I was in Texas at the time too. And, I have to say that there were just even like, I guess that was a year into it, that when we had the big freeze, that also went along with that. That was another thing that just really pushed people to their limit. And our hospital was absolutely full with patients who were experiencing exacerbations of their eating disorders, as well as anxiety, depression, increased suicide attempts we've seen as well. It's just been ongoing from the beginning. And I think there was maybe a little bit of a lull in the very, very beginning because nobody was going to the doctor and people were just sheltered in place. And then as the pandemic continued, especially as we got into like the summer months and in the whole back to school time, we just saw an explosion. A lot of people didn't know, is it safe to go to school? Is it safe to go to school without a mask? If my state, county, city said, no, we don't need to wear a mask, there was just so much uncertainty. So yeah, pretty much right away with spikes a few months into the pandemic, once people were able to come in and get diagnosed and treated. Teenagers are supposed to be developing their brains during adolescence. We know that the human brain continues to develop until at least age 25 for some of the kids, a little bit longer. And that's when they're learning how to deal with peer pressure and bullying and crushes and pressure from teachers and all of these things. And we took that away. For one, for some kids, they were put in a situation where they were with family members or living with other people who were at the limits of their coping skills, or perhaps even harmful to the young people. Perhaps they were stuck in an abusive situation and they didn't have that extra safeguard of teachers to look out for them. So kids are supposed to be developing their coping skills during this phase. And by being at home and at school and in church and in, community groups, you get to learn different ways of coping from different people. But when we're on lockdown, you're only getting it from like a handful of people and maybe television and social media, which can sometimes show you some negative coping skills. So adults, hopefully all of us have a variety of tools in our toolkit, some quote unquote positive skills like deep breathing and yoga and therapy, and just socializing with friends and expressing our feelings. And some people with negative coping skills, substance use, or just holding in their feelings and exploding at times. So those are kids that we want to, look out for and certainly help develop a variety of skills. And I think that was one of the challenges that the kids are missing, this key developmental phase. And we have to do some catch-up work for that.
The article was just a beautiful article, and it touched on so many things. I've often thought about COVID and our children, and what has impacted my thoughts is the amount of time COVID lasted is so much more significant to somebody who's 6 years old. So COVID comes along, it's that's a third of their life that it has been affected by a disease and fear. You think, you don't want your children to grow up fearful, and the whole mask thing and all that. I mean, and it was easy to wear a mask, to keep people safe, but you just wonder what goes on in their little brains. And then you also think about the rites of passage, right? The kids who graduated during COVID and then go off to the first year of college, and, they didn't have their senior ball, they didn't have their graduation, and the first year of college is remote, so they missed out on a lot of things, and all those things have to have an impact. And that's sad. It's reality, but it's so much. It's hard on adults, but it's got to be so much harder on our young people. And I know a handful of young people who were very well adjusted, who this really has affected profoundly and changed their lives. So
Well, the one thing in the article that I saw was that, and there's so many people who have been affected by the death of someone from COVID, and it's hard enough when it's an elderly person and as an adult, you can maybe cope with it a little bit better. But it said 140 children experienced the death of a primary or secondary caregiver. And that just astounded me. And then that they had no support out there for that. I mean, they weren't able, they were just shuttered at home and didn't have anybody to help cope with that and process that.
Right. Yeah. I think you bring up an excellent point, and I think this is part of what led the American Academy of Pediatrics, the Academy of Child and Adolescent Psychiatrists, and the Children's Hospital Association to declare a mental health emergency, a pediatric mental health emergency. We know, and that was back in October, right? October 2021, that they said 140,000 kids lost a primary or secondary caregiver. It's obviously more than that by now. And that's just our country. That's not thinking globally. And when we think about, as you mentioned, experiencing that loss, but also experiencing that without additional supports. People had to have funerals on Zoom. You couldn't have the aunt from, California fly in and give you that help and support because that was not safe and that would put everybody else at risk. And it's just been a very challenging time that all of our supports that we traditionally had weren't there. And so we had to develop new things. And I'm a silver linings kind of person. So I think one of the silver linings in this is that we pushed forward with Zoom and, telemedicine visits and all of these things. And that gives some comfort, but it's not the same as a hug. I mean, there's just, sometimes where you just need that personal presence in the room and that space to just be with a person calmly. So I think the silver lining is we pushed forward on a lot of things. And I like to think the other silver lining is that we can talk about it now. One of the quotes that I like from, I saw this, it was a grand rounds with Harvard School of Public Health, and they had folks from the National Association for Mental Illness, NAMI, there. And they said, before the pandemic, let's say hypothetically 3 out of 5 people were experiencing anxiety or depression or had some sort of mental health effect. During the pandemic, it was 5 out of 5. Everybody felt something, So we can talk about it now. And I'm hoping that this will destigmatize mental health and mental illness in a way that we haven't had in a long time.
Yeah. I read something on LinkedIn about mental health and the explosion of the people coming out, especially celebrities now are coming out, athletes and celebrities are coming out. And I said, it's always been there. And it's always been an issue, and it's always been undertreated. And now, because of COVID, it has brought it to light. And that's a good thing, because I hope that the insurance industry drives treatment many times, right?
Yes.
So we won't go into that right now, but hopefully that they, I know they love the virtual platform. So, and, I didn't think about it initially when the whole Zoom thing and all these things started, but it probably drew more people out than would actually go to an office, maybe, right? Because they felt more comfortable.
Yes, it's fascinating. It was one of the things that spurred me on to, do something that was in the back of my head, having my own private practice, because I knew telemed was coming down the road. And I think as the regulations changed with states and certainly with payers, that made it more accessible for folks. But what's been fascinating to me is to see that there are some people who are they're like, nope, don't want to do telemed, need to see you in person. I want to see you in an office somewhere face to face. And it's really fascinating to see those differences. And it's not just, I think a lot of people think it's older folk who aren't used to technology. I'm like, no, there's some kids who really want to be with you in that room and have that quiet space and that whatever it might be, that energy, that calming presence.
Oh, absolutely.
To touch their hand or hold their hand, or like you said, just give them a big hug. And
I don't think there's anything that takes the place of being with someone. I mean, I think COVID has taught us that, how important that is. But I think telemedicine has been catapulted a decade advanced ahead because of COVID. And I think it's a great resource too, some of the time. And it's sometimes during COVID, it was all we had. And, we've utilized it, and we've all gotten a lot more familiar with technology, and that's a great thing. So I think hybrid seems to be like a very popular term now. And I think we're going to be hybrid forever. So
yeah. I think so. So. And, there's certainly advantages to it, that you don't have to, when you're doing a telemedicine visit, you don't have to stop what you're doing, drive across town, get out of school, get out of work, get somebody else to pick up the other kids, all of that and stuff, you can just pop on and call.
Right. So you can see more people, you can be present in a different way with more people than you could have traditionally.
Yeah. Yes, absolutely. And I think one of the other things that I liked about it, talking about being in the same space with a person, when patients come to our offices as doctors, therapists, whatever, we made that space whatever we want. But for me, it was fascinating to be on a telemed visit with somebody and be able to see how they have or have not decorated their room. That gives me a little peek into their interests and their mood sometimes, if it's a complete disarray, that could just be, that's how they like it. Or it could be a sign that they were struggling, or if there's a hole punched in the wall, what happened there?
Right. Right. And what's going on in the background too is sometimes very telling. So, yeah.
In helping people with their mental health, it takes a village. It's not just one person. And part of that village is the parents. And
yes.
So how do the parents support their children during these very challenging times with their mental health?
Yeah, that's great. I think it varies. I think some parents have been able to be more vocal about some of their own struggles. And I think that's helpful to a lot of the young people. I think when folks are doing that, we need to make sure that we're sharing that information in an age appropriate way. Just like, you don't talk to a 5-year-old about the uncle with alcohol use issues. You might say, Uncle Bill is struggling with X, Y, and Z, or he's not feeling well, that kind of thing. So I think, being mindful of where that young person is developmentally, but also making a safe space for them to talk about their feelings. And the other part of that is if somebody isn't able to do that, then I think they're modeling sometimes some negative coping mechanisms. And those are the folks that I need to, I think we all need to be a little bit more concerned about. Quite a few parents that I've seen who've been, for lack of a better term, burnt out and just at the limit. We live in nuclear families, right? Most of us. So there isn't that extended support when we're put in quarantine, and it's mom and dad and kids, and one parent might have lost their job or have their job threatened, and we can't go over to grandma's and just hang out and get, tea and sympathy and the support we need. Then that's a challenge for everyone. So I think, it works both ways. For parents who have great coping skills and have taken care of themselves, I think it's been helpful. For kids in situations where they're seeing some unhealthy or negative coping skills, it's even more challenging. And I worry that we're not even seeing them.
So it's been said to me many times in the past couple of years that we really don't have a mental health system. We have silos of mental health. And depending on where you are, that's, the treatments vary. Mm-hmm. So you think we should look at a more comprehensive redesign for mental health for our children that includes the medical community and the educational community, and the spiritual community, and working together more closely so that these kids aren't slipping through the cracks?
Yes, yes, and yes. I love that idea. I have been thinking even back in little med school days, I'm like, we need there's parent teacher association. We need a physician teacher association. So I don't know if I have the resources to make that happen, but if you guys or your listeners do, by all means, I would support that, because I think, there's not enough of us. There's not enough. There's 10,000 maybe child and adolescent psychiatrists in the country. There's less than 900 last time I checked adolescent medicine, board certified adolescent medicine providers. We might have a few more because board exam just happened in March. But it's still not enough. We've got 42 million adolescents in the country. We know that about a third of them have experienced some anxiety or depression that's at a level where it's diagnosable and impairing their day-to-day functioning. And that's not including eating disorders and other stressors. And we need more people. And there's not going to be enough of us, and it takes very long to train us. So we need to leverage everybody else to be able to do that and help share our message. And that's part of why I started the consulting firm, Adolescent Medicine Consulting, because there aren't going to be enough of us. And even if we get all the pediatricians trained up, that might help. But we need time and, to go back to the insurance question, appropriate reimbursement for that time and services. And care coordination, it's intensive work. It's absolutely rewarding, but it's intensive work. And so by those of us who have specialty training, teaching others what we know, how to identify, teaching some coping skills that can go through the school, I think that will help make that safety net, that system that we need and don't really fully have yet. I know one of the things that I definitely wanted to include in the article was the information from the National Network of Child and Adolescent Psychiatrists. They have started programs in every state now. Well, almost every state. I think there's some that are still blossoming. But they are using a model that was developed in Massachusetts in the early 2000s, where the psychiatrists are basically on call for pediatricians and primary care doctors. So if they see a child who screens positive for anxiety or depression in the clinic, or if that kid was on medications from another provider, they can call and get a consult and get a response within a few hours instead of the months now that it's taking. I mean, I heard from a colleague in New York City, where it has one of the highest concentrations of child and adolescent psychiatrists, that one facility had an 18-month wait for an appointment, which, I mean, you might not even be a child anymore by the time you get your appointment. So we need to do more, and we need to create that system. I also like that you included spirituality in that, and whatever that might mean for patients and families and schools. My high school drama teacher was actually not affiliated with the high school. She was somebody we worked with in the community. Miss Tina Satin, one of her quotes that I love was, when they took prayer out of the schools, they didn't replace it with anything. And I was very fortunate to have had a humanities education that was focused on arts. And I feel like that helps. That brings that human and spiritual component to education. And if we don't have that there, then we are not fully developing the adolescent human as best we can.
Yeah, it's not about religion, it's about spirituality, And
Well, connection, whatever you believe.
Yes.
But for best and highest good for all of us.
I mean, we didn't go to in-person masses for almost 2 years, and we just started going back, and oh my God, what a wonderful feeling it is to be back and with the people around us, and it's fabulous. So
we took a lot of things for granted before, and I think that we won't do that for a long time again. So that's for sure. When I think of pediatricians and adolescent medicine doctors, you are the most compassionate, kind, caring people, and you love children. You love our children, and it's a very special relationship that you have. I remember our children going to the pediatrician and what a big deal it was and what a nice connection it was. And I remember one time our daughter had her finger got smashed, a lid came down on it. And the pediatrician, I took her and he took one look at it and he kissed her finger. I mean, it was just like such a sweet thing to do. And I think that this has to have impacted the pediatricians and adolescent medicine doctors profoundly too, just to not have had their regular connection with their patients and with the families. And I think people don't think about that, and people don't also think about how burnt out you become. And I know you touch on that in the article a little bit too, but another thing that we took for granted is that, you're superhuman people, but you're human. And it's important for you to take good care of yourselves too. But it had to be very hard for you to experience this and watch the young people who you love so much going through this.
Yes. I'm glad you brought that up. I think Stoicism has been celebrated, made sacred in medication, in medicine. And I think that is fading now. It needs to fade. We are human. We need time to feel our feelings, process our feelings, take care of ourselves. And that is, again, hopefully a silver lining to this pandemic, but it was not one that is bought easily. There were unfortunately increases in physician suicides. There are massive shifts happening in the system as it is right now, with providers recognizing that perhaps the system that we're in does not give time and space for us to do our healing work. I notice, Linda, that you're also a Reiki master. And I think one of the things that I like about that tradition is that you have to take the time to do your self-care in order to provide that healing for others. And we need to do that as physicians. If we are not well, if we are not taking our self-care time, whether it's, and not just physicians, dietitians, nurses, therapists, everybody, if we don't do that, we can't do what we need to do for patients, and we can't heal. And for pediatricians, you bring up a great point. Pediatricians make not much compared to everybody in medicine in terms of financial reward and gain. But the joy of seeing a kid and helping them be healthier is what gets us going. And that's like absolutely priceless. For me in adolescent medicine, I would love seeing a kid who I knew was on the edge, who was in a place where they were depressed or having thoughts of hurting themselves or actually hurting themselves, and then helping them tap into their power as a young person and grow and develop and blossom and graduate high school and go on to college. And, I've been privileged to see some kids grow up. And when you can't have those milestones with them and you can't see the prom pictures because, everyone's on this respirator thing and, everybody's on lockdown and you can't, that was one of the things that, of course, if the young person was comfortable with it and I felt appropriate, like when we were saying goodbye, when they were ready to transition off to college, I would like to give them a hug and say good luck and go off and, see your doctors. Didn't feel comfortable doing that during the pandemic, for sure. I didn't want to make anybody sick and spread infection. So that was hard. That was hard for all of us.
Do you want to share with us a little bit about your consulting business and is it Pediatrics? How do you pronounce that?
Yes. So I'll start with that because I all the marketing people would be like, you're absolutely doing everything wrong by using this word, Meera, But Pediatrics is another term, the official term for adolescent medicine, and it comes from the name of the Greek goddess of youth, Hebe, or Hebe, however you want to pronounce that. And so I realized that for adolescent medicine, unlike some other specialties like geriatrics, this is where I think of the common example. Yes, we can see everybody in the age group, the well child and what have you. But as specialists with 3 additional years of fellowship training, we are more equipped to deal with the anxiety, the depression, the eating disorders, the reproductive health concerns, the brain development, academic issues, transitioning to adult care model for those young people with chronic medical problems. And that expertise, those more complicated teens, are who we are best suited to see. So I draw the parallel of one that is a little bit more pediatric as an example, a neonatologist. A neonatologist can see every well baby that's in the well baby nursery, but really they're best used in the NICU, where the baby was born premature and might have needed a feeding tube or breathing tube, all of these things. So that's where we are. Yes, I love seeing well adolescents and doing the well check, but really if we're using skills to the highest level, it would be seeing those more complicated adolescents who have reproductive health concerns, plus some anxiety, plus some depression, plus some eating disorders, or any combination of those. And so that's what I like to see in the practice. For the consulting business, my goal is to share some of those skills with my colleagues in primary care. So the pediatrician, the internist, the family medicine doc, who I don't know if folks know this outside of medicine, but pediatrics is the only specialty in that mix that is required to spend some time with an adolescent medicine specialist and learn specifically about pubertal development and the issues of adolescence. And because of the way our system is set up, for some pediatric residents, that might be more primary care. For some, that might be more sports medicine. For some, that might be more eating disorder care or gender care or other areas of focus. And so they might not get some specific training on anxiety, depression, and mental health issues. So those are some of the things. All of those things are topics that I'm happy to teach about: reproductive health, anxiety, depression, transitioning care. But just if we share those skills with others, we can expand the workforce and build that net. You mentioned that system, Jack, where we have more people to support our young people.
It's beautiful.
Beautiful. Before I get to this last question, and this is part of it, in the article, as a pharmacist, I know all about the pharmacological treatments of anxiety, depression, and all mental health, which I won't give my view at it right now. But you mentioned non-pharmacological treatments for reducing anxiety and stuff. And you have it down here for some adults and stuff. What specifically for children can you do?
Yes. So actually quite a few of the things that we use for adults can be used for children. I know Seema Kaneja was one of the guests on this podcast before, and I absolutely adore her.
She's awesome.
Yes. She, full disclosure, and in the spirit of doing, practicing what I preach, she helped me through some anxiety and some difficult times as well. And one of the things she taught me was the diaphragmatic breathing, and just using that method of breathing to slow your heart rate, slow your blood pressure, get yourself into a calmer space physically so you can be in a calmer space mentally and move forward. And that's something I use regularly and teach regularly to my patients. I think, for some younger kids, expressing those feelings and being able to actually say what they're thinking and what they're feeling. So sometimes it's using feelings wheels. There are some great resources out there. One that I learned from one of the nurse practitioners at the University of Rochester in the psychiatry department was free principal behavior charts, and tons of charts and resources that you can use to just help young people learn to do certain tasks at certain times, or learn to what makes them angry, or do a problem solving sheet. That's something I did with a young person recently. A situation happened, we were in a calmer place, and we could process what led them to get so angry that they broke part of the home.
Well, we could go on for hours with you here. We're coming up close to the end here, but is there something more that we should know about you and your vision, and just expound on whatever you like to?
Thank you. I feel the same. I know we could talk for hours and hours, and Hopefully I didn't ramble too much.
Oh my gosh,
Yeah.
we're so honored to have you, and you're such a wonderful guest. I feel like I've known you for a long time. So, and it is through Seema Kneja that we met. So, and Seema is a dear friend. So it's all these lifelong, or all these connections that just kind of align that amaze me.
Yes. It's funny how the world works. Yes. I think if I had to leave with some parting thoughts, I would say, number one, talk about it. I think what we're doing right now, the fact that you've made this space is wonderful. The more we talk about it, the more we get out of the silos and everybody talks to each other about their experiences and what we can do better, the better it will be. And just being where you're at with talking about it and making a safe space. And I think keep on learning. I most certainly did not graduate medical school knowing half of what I knew today in terms of caring for patients with anxiety, depression, all sorts of health concerns. So I'm constantly learning. I'm learning from other healthcare providers, therapists, dietitians. I'm learning from my patients. Sometimes I'll ask them like, hey, what'd you do in your therapy session? And they'll tell me a technique and I'm like, that's awesome. I'll go Google it and, start incorporating that into my practice. And I think we can all do that, learn from each other. It doesn't have to be provider to provider. And being kind to yourself, first and foremost, and knowing, I think this is especially for us as in the healthcare field, to address your question, Linda, we have to recognize that we're not superhuman and give ourselves time and space to say, I'm tired, I'm hungry, I need to go to sleep, I need to take care of myself. And that's okay. And being kind to others, because nobody knows what anybody else is really going through. And so making sure that we are kind to ourselves and as kind to others as best we can be.
I love that. That's so well said.
Yeah. Well, if we could just clone you and Seema and
we're working on it.
It's interesting what you say about your training or your education in medical school, and you guys go to school forever, and about our story about Emily, and when Emily was first struggling and I took her to the doctor, I just was naive enough to think that they knew exactly what to do to help her, and finding out how little, education they had in eating disorders. And you're saying it's, little education in so many things. And, I don't know, maybe that needs to be revamped too.
Yes, we're absolutely working on that. And that's definitely part of what I'm doing, what some of my colleagues are doing. We're trying to get the word out and raise awareness, because 30 million people is the estimate that we have are affected with an eating disorder. And it's probably more than that, but these are the estimates that we're working with. And
well, that's the other thing too. It's 70 million people worldwide, and 30 million that we know of, right? And 30 million are here in the United States. So it's just like the anxiety thing. There's 7% worldwide, but 20 to 30%. So what are we doing in this country? And obviously, there's not enough qualified practitioners to deal with it. So that should be a major focus of the medical schools in the future.
Absolutely. And it is changing. It's part of why I'm on faculty in 2 places right now. We're trying to just get as much information out there as humanly possible. And it, I guess, another good thing from the pandemic to put a silver lining is in 2020, I had a presentation for Texas Pediatric Society about eating disorders, and it was called First Do No Harm. Talking to pediatricians about some of the things that we do that might unintentionally trigger a patient who is experiencing an eating disorder, and how we can recognize patients with eating disorders. And I decided to leave that up on the web for, just free and for people to see, so that hopefully we can get more people reflecting on some of what we've done. Yeah, that's a whole other hour in the medical field that just makes us hyper-focused on these numbers that are only a fraction of what we need to know about a person's health.
Yes, and your physician, a pediatrician, can usually tell if you have a problem long before you get on the scale. You know, that if you're having an issue and it's, it's an emotional thing, and we've learned so much. We tried to, we got our hands onto everything we could initially, and we've learned so much even since Emily's passed, and that's all we can do is just pay it forward and let's try to educate as many people as we can and be the support that we wish was there for Emily and the support that was there for us. So that's kind of our focus and our mission. And we're going to be starting our own non-for-profit charity just for those reasons. So very soon.
Great.
So yeah.
Yeah.
But anyway,
Great.
we should probably sign off because you probably have patients to see, but we could talk to you all afternoon.
Yeah. And we are so blessed
grateful
to have you here today, and thank you so much. And thanks to our listeners. You guys are the best too. And please help us get the word out about Once Shattered, Picking Up the Pieces, because everybody's mental health matters. So please tell your friends, share this podcast, and rate and review it on the platform you're listening to us on. And have a great day. God bless you all.
And thank you again, Dr. Meera Beharry. You're very special, dedicated, compassionate pediatrician and adolescent medicine doctor, and we feel honored to have had you here. We'd also like to thank Rock Fox Recording and Production and sound engineer and producer Scott Fitzgerald for producing our podcast and so much more. This is a place to record your podcast, record your audiobook, or do a legacy cast for your loved ones. Thank you, everyone, for listening.